I'll go from the beginning. All right. So this session again is about routine coagulation tests, and these are the topics. The focus will be mostly on the regular stuff you will deal with in your routine
Sorry,
assays.
are you presenting right now?
Yes. Can't you see it? I can see it. You can't see my slides?
No, we cannot see.
Really?
Can you stop presenting and then try presenting again?
Oh, okay. All right. Now can you see?
Yeah, perfect.
All right. Good. So what I was saying is we will go over the routine, the basics, not the issues, how the assays work, what are the things that can have impacts, and so on and so forth. Then I will talk in this section about when you have abnormal results, what do you do next? And this is where we'll go over the mixing studies. Then I'll speak briefly about factor deficiencies and factor assays. And then finally, I'll talk about thrombophilia. Again, if we don't have time, I would rather we take our time with the last two because they have some delicate details that we should not rush over. We can always have another session. So for a beginning, just give me a moment. So PT, PTT, fibrinogen, and thrombin time. Now, generally, these four tests are meant for screening. I'm sure you see them all the time. They're used for pre-surgery screening if someone has bleeding, screening if someone has thrombosis. So these are meant generally to give you an overall idea about the hemostasis status of the patient. It doesn't diagnose anything specific. It doesn't give you any specific information. It's a general idea. Now, PT, as you know, is prothrombin time. APTT is activated partial thromboplastin time. Fibrinogen is obvious. TT is thrombin time. Now, PT, TT, APTT, again, are not specific. They don't tell you anything in particular other than this part of the hemostasis system is functioning well or there is an issue somewhere. Fibrinogen, of course, tells you this is the quantity of fibrinogen you have, but if it's abnormal, this can also indicate something is wrong somewhere with fibrinogen itself. All right, we will come to the details, of course. Now, when these tests are prolonged, we generally have to dig a little deeper. If they are normal, everything is fine, generally speaking. But if they are abnormal, we cannot say this particular thing is wrong with the patient. We have to go to more studies, mixing studies, anti-TNA assays, lupus testing, factor assays, and so on and so forth. This is where we go into specialty testing. Fibrinogen in general is requested for variety of reasons. Of course, PT, PTT, we understand, pre-surgery screening, bleeding issues in general. Thrombin time is a bit more specific. We'll talk about it. Fibrinogen in general is requested for few reasons. It's not always requested as part of routines. Depends on the practice. From country to country, it differs. Some countries, they request it as part of the routine, PTT, PT, FIB. Some countries, they request it only when needed. Again, depends on the doctors, depends on the practice. Now, one small point. As you know, PT and APTT generally would be sensitive to fibrinogen deficiency. Then why would I request for fibrinogen? I mean, okay, fibrinogen test would give me the quantity. But if it's a screening assay, would it not be enough to just request PT and APTT and only if they are abnormal, I request fibrinogen? Now, one important point. PT and APTT are generally sensitive to fibrinogen if there is a significant deficiency of fibrinogen. If there is just a mild deficiency of fibrinogen, meaning fibrinogen is below the reference range, but not very far below the reference range, then at that point, PT and APTT are very likely to be normal. So some doctors, they are interested to know if the patient has even a mild deficiency of fibrinogen, because in some clinical cases, this is quite relevant. That's why some people, they decide to go for fibrinogen even when they request PT, APTT. So 3 all at the same time. Okay. Fibrinogen is relevant for a variety of issues such as DIC, disseminated intravascular coagulation. If someone is taking fibrinogen replacement therapy, in pregnancy cases, because generally fibrinogen tends to go up in pregnancy. So sometimes we need to monitor that it's not too high, and so on and so forth. Okay, so this is just a quick insight into this. To the right, you can see this. You can go over it as on your own time. I will not read every single line of it. Okay, these are the points where it's relevant for me to monitor each of these tests. Now, some important points about the tests themselves. Now, before I go any further, I need to ask you, do you want me to elaborate on the principle of the test, the way it works, or is this point clear? Because the rest of the slides, they rely on you knowing the principle of the test. The basics, I'm not talking about something deep.
Yeah, please tell the details, the principle, everything.
Okay, all right. Now, PT, I will not show you the, the intrinsic, extrinsic, and all of that. I'm sure you remember at least some of it, but I will assume you don't remember, but I don't need to show you all of the pathway. It doesn't matter to me. PT, prothrombin time, is a historical name because prothrombin is factor 2, but PT as a test, it activates, or the reagent really that we add, the PT reagent, activates factor 7. Factor 7 activates factor 10 and 5. Factor 7 activates 10 and 5. 10 and 5 work together, then they activate a prothrombin or factor 2. Then factor 2 activates fibrinogen, then you get a clot. So prothrombin time, why did I call it the prothrombin time and not factor 7 time? Prothrombin time is actually a historical name because by the time the doctor who discovered it, he did not realize, or people read at the time did not know that there is factor 5 and 10 and 7. So they thought this is the time it takes a prothrombin to be activated and to change fibrinogen to fibrin and get a clot. So prothrombin time is a historical name. PT as a test monitors the activation of factor 7 by the tissue factor. Factor 7 then activating factors 10 and 5. 10 and 5 work together to activate factor 2. Factor 2 then activates fibrinogen into fibrin. Fibrin is the one that forms the clot. So if there's an issue with any of these, if there's an issue with 7 or 10 or 5 or 2 or fibrinogen, PT will be affected. Okay, how about APTT? APTT is activated partial thromboplastin time. Let me break this down for you. Now, thromboplastin is actually the reagent of PT. PT reagent technically is called thromboplastin. Thromboplastin is also a historical name because when they discovered that there is this thromboplastin thing, they thought it's one thing. But then as studies went on, thromboplastin was realized to be actually phospholipids and something called tissue factor. Tissue factor is a protein that's normally present in the blood, and tissue factor is what activates factor 7. So partial thromboplastin is your tissue factor minus the phospholipid. So again, partial thromboplastin is the tissue factor minus the phospholipid, because thromboplastin, the complete thromboplastin, is phospholipids plus tissue factor. Okay? Because if I add thromboplastin into my plasma, basically this is a PT test, because again, PT reagent is simply thromboplastin. So if I add just thromboplastin to my sample, then I'm running a PT test. I'm no longer running an APTT test. So when we separate the phospholipids, when we separate the tissue factor, and we are just left with phospholipids, now we can activate the plasma, the coagulation factors in a different way. This is where the name activated APTT comes from. I need something other than the tissue factor to activate my coagulation factors because I removed the tissue factor, which is the activator in PT. But I'm not running PT, I'm running APTT. My activator can be one of many things. Silica can be an activator of the APTT test. Ellagic acid can be an activator of the APTT test. We have also glass. Kaolin, for example. In CK breast, cephalin, kaolin, cephalin is phospholipid. Kaolin is something like a glass, basically. It activates your intrinsic pathway. That's why if you collect your plasma in a glass tube, your plasma will end up being clotted because the glass carries a negative charge, and the negative charge will cause the clotting cascade to start. The intrinsic pathway, it causes it to start. So activated because we added something that activates the intrinsic pathway. Partial thromboplastin is because we remove the tissue factor from the thromboplastin. Otherwise, you are just running a PT test. And time is the clotting time. So the main difference between PT and PTT is really the reagent that you use. PT, we activate the extrinsic pathway, factor 7. Then we activate the common, we get a clot. APTT, we activate the intrinsic pathway using an activator. That can be glass, that can be kaolin, that can be silica, that can be lactic acid, depends on the manufacturer and the reagent. We activate the intrinsic pathway, then we go to the common pathway. The intrinsic pathway includes factors 12, factor 11, factor 9, and 8. 9 and 8 work together. 9 and 8 activate factors 10 and 5, let's say. Then the common pathway 10 and 5 activates 2, 2 activates fibrinogen to fibrin, then you get a clot. The main difference between PT and APTT, again, PT has tissue factor, APTT does not have tissue factor, it depends on the activator. Both of them have phospholipids, both of them need calcium because some coagulation factors, they need calcium to work. Without calcium, you will never get a clot. Both PT and APTT need calcium. Now you may ask me, but I only use calcium chloride for the APTT test. I never use calcium chloride for PT. Yes, because actually the calcium chloride is the solvent you use to prepare your PT reagent. When you open the optimal kit, you have a solvent, liquid, and you have lyophilized reagent. The liquid is actually calcium chloride. Okay, so you will always have calcium for PT, you will always have calcium for APTT, otherwise you will not get a clot. So these are the main differences between PT and APTT. One very critical difference as well is that PT is not sensitive to heparin. Why? Very simple, because manufacturers put a heparin inhibitor in PT reagents. Okay, if you are interested in knowing why, please note this down. I can discuss it with you at the end. Okay, because it gets a little not very complicated, but I don't want to waste the time talking about this point now. But reagents in general are not sensitive to heparin. APTT reagents in general are sensitive to heparin to varying degrees of sensitivity. We'll cover this point. Another point, PT in general is not sensitive to lupus. APTT in general is sensitive, varies from reagent to reagent, the sensitivity, but APTT in general is sensitive to lupus. Again, varies from reagent to reagent, the amount of sensitivity to lupus. Okay? Why? Because PT has far more phospholipids in the reagent than APTT. What does that have to do with lupus? We have to talk about lupus to explain. But PT reagents in general are poorly sensitive to lupus. So this is another very important distinction between PT and APTT. That's why if you look at lupus patients, PT is generally normal, not affected, whereas APTT can be significantly prolonged depending on the reagent. Again, we will elaborate on this point a little later. Now, fibrinogen assay, I will talk about it a little more. Fibrinogen assay, the reagent for fibrinogen assays is very simple. We only use activated factor 2. We call it thrombin. So the reagent for fibrinogen is just thrombin. We add the thrombin on top of diluted plasma. Okay, we dilute our plasma 1 to 10 or 120, depending on the manufacturer. Then we add the thrombin on top of the diluted plasma, and then you record the clotting time. From the clotting time, you use a calibration curve, then you say, I have this much gram per liter fibrinogen. I have this much milligram per deciliter fibrinogen. Okay, so I dilute the plasma. I add the thrombin on top of it. I record the clotting time, use the calibration curve then I will get the concentration of fibrinogen. Finally, thrombin time, from the name, very simple test. Thrombin time, I add thrombin on top of undiluted plasma. So one of the main differences between fibrinogen and the thrombin time, in fibrinogen, I dilute my plasma 1 to 10 or 1 to 20, depends on the manufacturer. Stagocase, I dilute 1 to 20. In thrombin time, I do not dilute my plasma. So does this mean that I can use the fibrinogen reagent to run the thrombin time test? No, because the concentration of thrombin in the thrombin time reagent is different from the concentration of thrombin in the fibrinogen reagent. Usually fibrinogen reagents have significantly higher thrombin in them. Okay, so you cannot at all use the thrombin time reagent for the fibrinogen test or the other way around. Okay, thrombin time test, again, very simple. I add thrombin, activated factor 2, on top of my undiluted plasma. Since the thrombin is already activated, it cleaves fibrinogen into fibrin and you get a clot. Usually the reference time or the normal people will get a thrombin time result of less than 21 or 22 seconds. Depends on the manufacturer and your reference range. Okay, so do you want me to elaborate about these points a little more or should I continue? Are these basics clear? Does anyone have a question?
Continue.
Okay. Now, a little more details for you. PT in general, prothrombin time in general, is more sensitive to deficiencies in the common pathway. That is factor 5, factor 10, factor 2. And why am I mentioning this to you? It is because if you run factor assays, of course, we will talk about the details later on for factors, but if you run factor assays, when I run factor 10, factor 5, and factor 2, I don't use APTT assay, I use PT assay. The reason is because PT is more sensitive to these factors. Why? It's quite technical. We don't have the time for that. And it's not very important for you to know the why, but it's very technical. If you wish to know, we can talk about it at the end of the presentation. Please put a note and we can discuss it. We spoke about the PT reagents having heparin inhibitors, okay? In our case, the heparin inhibitor is something called polybrine. Other manufacturers, they use something called heparinase. Other manufacturers, they use something called protamine sulfate. It depends on the manufacturer. In a Stago case, we use polybrine. Now, we spoke about this point. We said PT reagents are generally insensitive to lupus because they have very high levels of phospholipids. Okay, why? It has to do with the way they are manufactured. Not very relevant to us, but we just need to know that PT is insensitive to lupus. So PT as a test is not very useful to screen for lupus. Okay. Now, speaking about INR, INR in many cases is misunderstood because some people think that they can use INR for everything. That's not true. INR, according to CLSI, and according to the original publications that really suggested and evaluated INR, INR was really evaluated only from the range 1.5 to 4.5 INR and only for patients taking warfarin. Okay? So again, INR was only validated in the ranges 1.5 to 4.5 and only for patients taking warfarin. If we use INR to study patients, for example, who have liver disease or liver issues, INR results will not be accurate and will not really reflect the status of the patient because you will tell me, okay, but both of them will cause coagulation factor deficiencies. Yes, but completely different mechanisms and with completely different timelines. We will not go into the details. But INR is only validated for patients who are taking warfarin, nothing else. But you might tell me, okay, but we use INR to report normal results. Or we can say, okay, if the patient has less than 1.1 or 1.0 INR, they are normal. CLSI recognizes that some doctors or some physicians do that. They say you can do it, but if you can avoid it, it's good. But they don't say that you cannot do it. Okay, so again, CLSI says, okay, no problem, you can use it, just be careful because INR is validated just for patients on warfarin. All right, but for any other purposes, CLSI strictly says no, do not use it. Okay, so INR is only validated for people who take warfarin for us to monitor their therapy. Okay, and depending on the status of the patient, the acceptable range of warfarin can be different. For example, most patients, the acceptable range of warfarin, of INR, sorry, if the patient's taking warfarin is 2 to 3. For some patients, it's 2.5 to 3.5. For example, some patients who have heart valve replacement, the warfarin range should be 2.5 to 3.5. But again, that's up to the physician to decide. Now, one very important point that can cause serious confusion in the lab. the readings of INR can be dependent on the reagent because, as you know, PT reagents, they can be either recombinant reagents or extraction reagents. What do I mean by that? Remember I told you PT reagent is something that we call thromboplastin. Thromboplastin is simply when basically people started to study this. Thromboplastin is simply extracted from animals. So for example, from ox brain or from rabbit brain, our neoptimal reagent is very simply dried rabbit brains where the thromboplastin was extracted. So we take the rabbit brain, we process it, we extract from it tissue factor that is bound to phospholipids. Okay? Now, this process can be, of course, laborious, costly, and so on and so forth. And standardization is difficult because, you know, this is biology. These are animals. You cannot always make biology work the way you want it to work. So there's a lot of work for you to make sure you have a lot of consistency between lots that you manufacture. So with time, new reagents were manufactured that use recombinant tissue factors. So we no longer need animals to produce our thromboplastin. We can work in labs, take the thromboplastin, okay, produce tissue factor that is recombinant. So now we have recombinant PT reagents, recombinant thromboplastin PT reagents, and we have extraction that is extracted from animals, PT reagents. Recombinant PT reagents are very sensitive to factor 7 deficiency. Factor 7 is the first coagulation factors that drops when the patient takes warfarin. That's why we use PT test for warfarin monitoring, but not APTT. All right, it's factor 7. So since recombinant is very sensitive to factor 7, you might tell me, okay, but this is good. I want it to be very sensitive. Not really. Because the INR original studies, they used extraction PT reagents, means the validated INR ranges that you have now were originally based on extraction PT reagents. Okay, which means that INR usually reported with extraction reagents more or less is in a way more accurate. It reflects the patient's stats a little better. Now, I'm not saying that recombinant reagents are bad. No, there's a lot of ways to mitigate this difference. But my point is, some cases were reported, some studies have reported that if you compare a recombinant reagent to an extraction reagent, you might see differences in INR in some patients depending on the patient status, especially in the first days when the patient starts to take the warfarin therapy. So if my patient is within, let's say, the first 5 days of starting the warfarin therapy or first week, if I compare the results between recombinant and extraction PT reagents, you will see significant differences in INR. Actually, it's not recommended to really monitor INR in the first few days of warfarin therapy. Okay, this is one of the reasons. So I hope this point is clear. Is this point clear? Because it's an important one. Do you have any questions about this one? I will not wait until the end of the presentation because this is an important one.
No
Any questions or it's clear?
Clear.
Okay, very good, very good. Now moving to APTT. APTT, as you know, is used to monitor many things. So we use APTT to monitor if you have factor deficiencies, if you're factor 8, 9, 11, 12, maybe 2 is missing, 5 is missing, 10 is missing. Okay. So factor deficiency is one of the main reasons. We also use it to monitor if the patient possibly has lupus antibodies. We can also use it to monitor if the patient has heparin contamination, or maybe the patient is taking heparin treatment. Heparin contamination from IV, for example, from IV drips, IV, what do you call that? You know, when the patient is intubated, I lost it. You understand? IVs. I forgot the word completely. Anyways, because as you remember, I just said, and as you can see, APTT has no heparin inhibitors in it. But you may ask me why. I don't want heparin to interfere with my APTT. Because still a lot of people use APTT test to quantify the amount of heparin in the patient's blood. Now, very, very important point. APTT is far, again, APTT is far from being the ideal test to monitor heparin in the patient's blood. It has tons of problems when it is used to monitor heparin. Some labs still use it, some countries still use it. That's not ideal, but anyways, it is still used for that. That's why we do not add a heparin inhibitor in the APTT. Okay, that's why APTT is sensitive to heparin, especially unfractionated heparin. Okay, it's less sensitive to low molecular weight heparin. It's not very predictable, the response, but it's insensitive to something called fondaparinux. It's a type of heparin as well. Okay, it's rare, but if the patient is taking fondaparinux, generally it has no impact on APTT. Now, one very important point that many labs will face. You can never compare APTT reagents. For example, if you use CKPrest side by side with PTT Automate, and Madame Marisha, you remember we had this discussion when I visited, the results between APTT reagents can differ quite significantly. And the reason behind that is very simple. The composition of the reagents is different. This composition can impact the factor deficiency sensitivity or factor sensitivity of the reagent. It can impact the sensitivity to lupus. It can impact the sensitivity to heparin, and even to other things like some kinds of antibiotics, some polyethylene glycolated medications, even CRP in the patient blood. And these are all very commonly encountered things, especially if you have a big hospital or specialized hospital. So the point about APTT, and I will elaborate a lot about APTT because it's quite important. For APTT, no such a thing as a universal APTT reagent exists. No one who knows what they're talking about can tell you this APTT reagent is suitable for everything. That simply does not exist. It's physically impossible. Why am I saying that? Because you can either have an APTT reagent that is sensitive to heparin or not sensitive to heparin. You cannot have both at the same time. You can have an APTT reagent that's either sensitive to lupus or not sensitive to lupus. You cannot have both at the same time. It's impossible, right? So if I want my APTT reagent, for example, primarily to detect factor deficiencies because I'm screening my patient before surgery, okay, then ideally I should use an APTT reagent that is not affected by lupus or poorly sensitive to lupus and poorly sensitive to heparin, because these things generally do not have an impact on surgeries, okay? If I want a reagent of APTT that can detect any abnormality of coagulation in the patient blood, I must use a reagent that is sensitive to factor deficiency, sensitive to lupus, and sensitive to heparin. Now, if my reagent is sensitive to all of these, then you should expect that this reagent will be more of the time or more significant period of the time out of the range compared to the first reagent that's not sensitive to lupus or not sensitive to heparin, because if it's not sensitive, it will be normal. So in this case, to simplify, in our case, PTT Automate is sensitive to everything. CKPrest is poorly sensitive to lupus and very, I would say, moderate to poorly sensitive to heparin, but very sensitive to factor deficiency. That's why if you compare them side by side, you will notice PTT Automate results more often are prolonged than CKPrest, and that has to do with the sensitivity. The same applies to any reagent on the market. You cannot compare two reagents of APTT because the results will definitely be different. What about if I use ratio? It will not work all of the time. It might work for some results, but in many other results, many other cases, it will not work. Because, for example, if the patient has heparin in their blood, PTT Automate might give you 60 seconds, CKPrest might give you 35. The ratio will be very vastly different. Okay, so this is a very important point that you have to keep in mind. You should never compare APTT results between reagents. Okay, and if you have two different analyzers, for example, one from Sysmex, one from Stago, the principle is different. This might have an impact on the clotting time, but most of the impact comes from the reagent itself. Okay, and this is very important to remember. So briefly about each point. Where is my mouse? Okay. Do you see my screen? Do you see this slide clearly? Factors levels?
Yes.
Okay, good. So, as you can see, I will not speak about the graphs much, but they're just there to convey the idea if you want to dig a little deeper. As I mentioned to you, the reagent sensitivity, the reagent composition, sorry, affects the sensitivity of the reagent to the factor deficiency, even within the same manufacturer, as I mentioned to you, PTT Automate and CKPrest. CLSI recommends that your APTT test result becomes prolonged if any of the factors levels is between 30 to 45%. Why 30 to 45%? Because generally above 45%, the patient has absolutely no clinical symptoms. The patient is normal. They don't bleed. They don't have problems. But if the patient usually drops below 30 to 40%, they will start to have clinical issues. That's why if my APTT reagent, for example, does not become prolonged until the patient has 15% factor VIII, for example, then if the patient has 20%, my APTT reagent is normal. But at 20%, my patient might bleed, right? If they go, for example, for a surgery or something. So in this case, the reagent is not sensitive enough. That's why CLSI says your sensitivity to factors for the APTT reagent should be between 30 to 45%. So if any of the factors, intrinsic or common pathway, is between 30 to 45%, your APTT reagent should be normal. If it drops below 30%, more or less, it should become prolonged. Otherwise, its sensitivity is not good. Then why don't we increase it to 60%? That is, APTT should be prolonged if we drop below 60%. But if your patient is at 50 or 55% or 45%, they're absolutely normal. If your APTT is prolonged, this tells you that something is wrong with hemostasis, but there is nothing wrong with hemostasis. That's why CLSI said 30 to 45%, not more. More is way too sensitive, unnecessarily. Less than 30%, it's way too poorly sensitive, okay? So balance is great in this case. Not too much more, not too much less. Now, sensitivity to heparin, this is an important point. The sensitivity to heparin, as I told you, can differ between APTT reagents. So to give you an example, and why I told you ratios do not work. If you look at this column here, see, by the way, these are all different APTT reagents. If you look at the APTT ratios when the patient is at the same dose of heparin, look at the variation in ratios. It can go from as low as 3, 2.5 ratio up to 12 ratio for the same dosage of heparin. So this is a huge difference, which tells you that ratios can no way make the results from different APTT reagents match. Okay, so that the sensitivity to heparin can differ quite significantly between APTT reagents. That's why you cannot use the therapeutic ranges for heparin from one reagent to another. And one important point, whenever we say heparin and APTT, as I told you, low molecular weight heparin, which you may know as Clexane, okay? Low molecular weight heparin effect on APTT is not predictable, meaning sometimes it might cause a prolongation, sometimes it might not cause a prolongation. So if you say, okay, my patient is having low molecular weight heparin, or no, I don't know, I will run an APTT test. APTT test might be prolonged, might be not, even if the patient is taking the low molecular weight heparin. That's why I can never use APTT to quantify low molecular weight heparin. I cannot use it to quantify fondaparinux. Again, fondaparinux is a type of heparin because fondaparinux generally has no impact on APTT. Only unfractionated heparin has a predictable effect on APTT. That's why people used to use APTT for unfractionated heparin monitoring and quantification. Okay? And this is a very important point. Now, when talking about lupus, that's the last bit about the sensitivity of APTT. When we talk about lupus, the main point we are concerned with here is the amount of phospholipids in the reagent, because that's the main point that can determine the sensitivity of the APTT reagent to lupus. The more the phospholipid, the less sensitive the reagent is to lupus. Sequeprest has a lot of phospholipids. It's poorly sensitive to lupus. PTT Automate has very little phospholipids. That's why it's very sensitive to lupus. However, CRP, C-reactive protein, can have a very similar effect to lupus on APTT reagents. That's why if you have a lupus-sensitive reagent like PTT Automate and the patient has severe inflammation and the CRP is high, in the case of PTT Automate, more than 85, I think, milligram per deciliter, if I'm not mistaken, or liter, then PTT Automate will start to be affected, even though there is no lupus, it's just CRP. Even some medications, as you can see here, see? Antiarrhythmics, these are for the heart, arrhythmia. Antipsychotics, antidepressants, anticonvulsants. All these medications can interfere with the APTT assays. So it's important to know what kind of medication the patient is taking, okay? Because it can affect the results of the APTT. Now, this is a quick summary of the APTT reagents variation. Now, see, these are 7 different reagents from 2 different manufacturers. They have very different levels of sensitivity. So plus means poor sensitivity, plus means moderate sensitivity, plus means very high sensitivity. So as you can see, different reagents have varying levels of sensitivity to different things. That's why you cannot really compare APTT reagents. You have your APTT reagent, you have to work with one APTT reagent at a time, or assign them for different purposes. And if you want a document that proves that or says so, we have a letter that is from our clinical development director that says the same. All right. Now, moving to fibrinogen. There's not that much to talk about in fibrinogen. Okay, it's relatively simple. Fibrinogen is given by some manufacturers as a result that comes with the PT test. We call that PT-derived fibrinogen because if you remember when I mentioned fibrinogen earlier, I told you fibrinogen usually works. I dilute my sample, 1 to 10 or 1 to 20, again, depends on the manufacturer. Then I add thrombin on top of it. We call this methodology Klaus method. Klaus is the name of the person who invented it. So Klaus method, dilute the sample, add thrombin, clotting time, calibration curve. Some manufacturers, they provide you fibrinogen with the PT result. So you just use the PT reagent. So we call that PT-derived fibrinogen. Now, we don't have that as a Stago. Actually, we had it, but we discontinued it, to be quite honest. And the reason is PT-derived fibrinogen is only accurate in the normal range. The moment your PT-derived fibrinogen value is out of the reference range, it's not accurate, whether it is higher than the reference range or lower than the reference range. Plus, another issue with this PT-derived fibrinogen, anything that can interfere with PT, like the patient is taking warfarin, the patient has deficiency with factor 7, 2, 10, 5, your fibrinogen results are completely inaccurate, okay? Because there's something else other than fibrinogen that's causing prolongation. So it has a lot of problems. So yes, it's cheaper. 100% is cheaper than buying a fibrinogen reagent. But there's a reason that the gold standard for fibrinogen testing is a Klaus method, because it does not have all of these interferences, okay? So the gold standard is a Klaus method. PT-derived fibrinogen, it has plenty of issues. That's why most labs don't use it. Maybe you did not even hear of it before, okay? Because it's not very common. Now, the next point is fibrinogen is used for many points, as I told you earlier. For example, DIC, if the patient's taking fibrinogen replacement and I want to monitor it to see the patient's response, should I adjust the dose and so on and so forth. Fibrinogen has plenty of other uses, really. It's used also in some things called scoring systems. We'll talk about them later on. So it has its uses. Sometimes it's used as routine screening. Sometimes it's used for more specialized purposes. So it's made in the liver. So if the patient is significantly obese, they have a lot of inflammation or trauma, for example, an accident, God forbid, then fibrinogen can shoot up. Pregnancy also can increase it. All right. So it varies a lot depending on so many reasons. Now, for us, the interest is the pathology. So, for example, if the patient has disseminated intravascular coagulation, DIC, we will talk about that later on. If the patient has a liver deficiency and so on and so forth, this all can mess with fibrinogen. That's all fine. Now, the thing that is more relevant to us in the lab. When I run a fibrinogen assay, if the result is normal within the reference range, then generally I can say that fibrinogen is okay in terms of quantity and in terms of quality. Because if the quantity is okay, the clotting time will be normal, let's say, okay. If the quality is okay, no mutations, no problems with the structure of fibrinogen, the clotting time will be okay. So the quantity I understand. The less the quantity of fibrinogen, the longer the clotting time. This is clear. How about the quality? What did I mean with the mutations? Some people, of course, as you know, there are many diseases that have to do with the mutations. Some people, they have a mutation in the fibrinogen gene, which means the fibrinogen itself can have issues. These people do not always have longer clotting time. Some people who have fibrinogen protein mutations, sometimes they have shorter clotting time, means fibrinogen will look higher than what it is. And actually, up to 25% of the people who have fibrinogen gene mutations, they actually have thrombosis, not bleeding. You would assume fibrinogen has an issue. Okay, it's not going to clot well. Then you'll have bleeding. That's not always the case. That's 50% approximately of the cases. Okay. So when I run my fibrinogen assay, I'm really looking for if it's low or high, because if it's normal, I can guarantee you the results are good for quantity and good for quality. If it's higher or lower than the reference range, then it can be a quantity issue or it can be a quality issue. How do I check this? Now, this is where you will go in a little more specialty assays. Okay. But if it's normal, we can generally say everything is normal. Okay. So this is a very important concept. So as I just mentioned to you, the patient may be normal if fibrinogen is low or high. Okay, but you'll tell me, yeah, fibrinogen is low or high. How come the patient is normal? I'll explain in a second. So if fibrinogen is low or high, the patient may be normal. That's around 25% of the cases. They may bleed around 50% of the cases, or they may have thrombosis around 25% of the cases who have clinical symptoms due to fibrinogen, that is. Some people, they actually have problem with fibrinogen, but they might be completely normal, whether it is a mutation or a quantity, okay? If you have abnormal fibrinogen, doesn't guarantee you'll have a clinical issue. Now, moving on to thrombin time. Just to remind you, thrombin time is a very simple test. I will just add thrombin to my undiluted plasma. Then I will record the clotting time. Why do I need such a test? Thrombin time is used for very specific purposes. If I want to quickly screen if the patient has heparin in their blood, or if I want to screen if the patient has thrombin inhibitor medications. Because we have heparins, heparins, they inhibit all the factors, especially factor 10 and factor 2. But we have also things like dabigatran or argotroban or hirodine. These are medications that specifically inhibit factor 2. So maybe before surgery, for example, we need to check that. Does the patient have any of this in their blood? So we use thrombin time because it's a quick test and cheap. No need to run anti-10 assay or anti-2A assay because these are very expensive. The other purpose thrombin time can be used for, thrombin time will be prolonged if you have fibrinogen degradation products in the blood. So for example, if the patient has DIC and DIC leads to a lot of fibrinogen degradation products in the blood, these can interfere with the thrombin time assay and cause its prolongation. So if thrombin time is prolonged, we can suspect heparin, we can suspect factor 2 inhibitors, like again, argatroban, dabigatran, and so on and so forth. Or we can suspect that maybe the patient has fibrin or fibrinogen degradation products in their blood, because these can physically interfere with the assay sometimes, okay, with the clot formation. So this is an important point to keep in mind. And the last bit about thrombin time is that if the fibrinogen itself is low in quantity or low in quality, it has a mutation or a structural issue, thrombin time will also be prolonged. Because if fibrinogen is low, clotting will take longer. If fibrinogen has a mutation, generally we will say that clotting time will take longer. So thrombin time will, in this case, be prolonged. And this is the point that I mentioned to you about fibrin and fibrin degradation products in a plasma. Okay. So we have approximately now 25 minutes. D-dimer, we have to give it its time. Should I push it to the next session? And now I will switch to mixing studies because you told me that you would like to have mixing studies at least. Correct, Madam Arisha?
Yeah, let's skip D-demo and move to mixing.
Understood. Okay. Any questions about the basics that we spoke about so far?
No.
Okay, good.
Wait, question Anita. Yeah, okay. Oh, it's not a question actually. I just want to maybe I correct question. I don't know. Actually, the dialysis patients, so what will be the best time to take the sample after dialysis or during
Again, what
dialysis?
patients?
Dialysis patients, when will be the best time for sample collection?
Dialysis. Dialysis. What are you looking for exactly in the
Patient,
dialysis patient?
maybe there can be an heparin contamination, right? That's
Again?
actually what I want. No. Heparin contamination might interfere the results, right?
So he's asking like
Absolutely, absolutely.
for dialysis
Hmm.
patients, what will be the best time to take samples? Because of heparin contamination. Yeah.
I don't remember exactly, but generally heparin can stay for a few hours in the blood if it's unfractionated heparin. Okay? So if I understood correctly, I did not read about dialysis all that much, to be honest, one long time ago. So I have to get back to some literature to give you an accurate answer. But in general, when unfractionated heparin is introduced into the blood, it takes some time to be cleared. All right, it takes few hours. It's relatively fast compared to low molecular weight heparin or fondaparinux, but it takes at least few hours. So you may have to wait up to 12 hours for it to really completely clear up before it causes an interference. After which it causes no interference to APTT, but that depends on the agent. But what exactly is the ideal time? If the patient is having heparin in their blood, okay, then maybe that depends on what the clinician wants to see. Because if the patient, for example, is on heparin, but this is anticoagulant therapy because they have, for example, a heart condition or they have thrombosis, then that's usually after 3 to 4 hours of injection. Okay, but now you're talking about dialysis. Is there any kind of standardized time for testing that reflects on a certain aspect of the patient's clinical picture? I don't know. I have to check. Okay, so are you looking for something specific in this case to monitor in the patient, or you're talking in general? You want to do a coagulation test, and what's the best time for collection? Just to understand what should I look for.
In general, what's the best time for collection?
Yeah, so that we can
Understood.
advise the nurses to collect.
Okay, understood. I will check this point for you. Let me note it down. So I'll get back to you, inshallah, with an answer. Just give me a second. Okay, I'll get back to you as soon as I get an answer to this one. I'll try to be as thorough as possible. All right, any more questions, or should I proceed?
Please proceed.
Sure. Okay. So now for PT and APTT, generally, we will go for mixing studies when we want to know what is the reason PT or APTT are prolonged. So for example, I got a patient sample. PT is prolonged, PTT is okay. Now, it can be one of the common pathway factors that's slightly deficient, that APTT is not sensitive enough, so it's not catching it. Or maybe PT, for example, factor 7, for example, is missing. APTT will not be sensitive to that. Maybe both are prolonged, both PT and PTT. So it can be something related to the common pathway. It can be another source of interference. It can be. How can we tell for sure? Or how can we at least narrow our options? We cannot run factor assays, all the factors every time PT or APTT are prolonged. It will be extremely costly. We cannot run lupus testing every time PTT is prolonged. We cannot run heparin testing every time APTT is prolonged. It doesn't make sense. So when PT and or APTT are prolonged, the next best thing to do, or the reflex, or the next best thing to do is running mixing studies. Before I go into the details of mixing studies very simply answer the question: is the prolongation in PT or APTT caused by factor deficiency or is it caused by an inhibitor? Again, mixing studies answer the following question. Is the prolongation in the PT and or APTT caused by factor deficiency or is it caused by an inhibitor? Now, don't assume that mixing studies will answer this question every single time with accuracy, but they will answer it most of the time with reasonable accuracy. Okay, mixing studies have their issues, have their complications, but then generally, they are much better than running factors or lupus or antitin A every time PT or APTT are prolonged. Okay, it's a very simple, cheap, simple test to run. So, what am I mixing with what? Why did I call them mixing studies? Now, imagine the following scenario with me. Factor 2 in one patient is 0%. They have no factor 2 whatsoever, completely missing. Okay? So if I run PT or if I run APTT, the clotting time probably will be more than max, too high. Correct? Because factor 2 is missing. Nothing will convert my fibrinogen to fibrin, no clot. Now, what will happen if I add 50% of factor 2 into the patient blood? Now remember, I told you, CLSI says ideally my APTT reagent sensitivity to factors is 30 to 45%. This is more or less applies to PT as well. Okay, so if my results, if my factor levels, in the patient blood are generally 50% or more, the clotting time of the PT and APTT test should be normal, within the normal range. Okay, again, if the factor levels in my patient blood, cool. Again, if the factor levels in the patient blood are generally at around 50% or more, the clotting time will be normal for PT and APTT. So going back to the patient with 0 levels of factor 2, how about if I mix my patient sample with an equal amount of something that I called pooled normal plasma? Pooled normal plasma is a plasma that I pool or collect from many patients. Recommendations are up to 40 normal patients, okay, or people. And this means that when I collect all the plasma from all the 40 people, the levels of factors will be around 100% in my plasma pool. So if I mix my patient sample with an equal volume, let's say 1 ml patient plasma, 1 ml of pooled normal plasma. Pooled normal plasma has 100% of factor 2, 100% of factor 5, 100% of factor 10, 100% virtually of all the factors, okay? So then this means that my patient sample has at least now 50% of factor 2 because 0% from the patient, 100% from the pooled normal plasma. Mix them together, you will have 50% because the 100% now is distributed over double the volume of plasma. Okay? So now what happens? I mixed my patient sample with pooled normal plasma. Factor 2 now is at least at 50%. If you run the PT test again and the APTT test again, they should give you normal results because I fixed the problem of missing factor 2, right? My issue that caused the prolongation is that factor 2 is missing. Now I fixed it by mixing my plasma with pooled normal plasma, which means the factor levels are all 50% or above, which means your clotting time is normal for PT and APTT. So if I run a mixing study and PT and APTT went back to normal, that is, for example, back to the normal range, let's say, okay, then that tells me the following. The issue that caused the prolongation in the first place is factor deficiency, because the only thing that I did when I did the mixing is I fixed the missing factor amounts. Did I remove lupus? I did not remove lupus. I just added factors. Did I remove heparin? I did not remove heparin. I just added factors. Did I do anything? No, I just added factors. That's all I did in the mixing study. So in the mixing study, if adding the factors put your results back to normal, means the issue that you had was simply missing factors in your beta and APTT, and missing factors caused the prolongation. However, if I do the mixing studies and I add the missing factors, but still your PT and APTT or one of the two is prolonged, that tells you that even when I add the factors, something is still causing the result to be prolonged. Again, if I run mixing studies, and this means I'll mix my patient sample with pool normal plasma. So this means I should have fixed the issue of missing factors. But still, my PT and APTT, one of the, or at least one of the two, is still prolonged. This tells you that there is an inhibitor in the sample that's interfering with your coagulation process. That's why I told you mixing studies tell you one of two things. If the mixing test result became normal, I say the patient is having a factor deficiency problem. I will run factor assess. If the mixing study result is still prolonged, I say, okay, I fixed the factor deficiency issue if it was there, but still the results are prolonged. So the issue that I'm facing is not really a factor deficiency issue. It's an inhibitor. You may ask, what is this inhibitor? A million things. It can be lupus. It can be heparin. Some cases it might be direct oral anticoagulants. It can be anti-factor antibodies. It can be. That's a completely different story. We will talk about it in the next session. Okay? So this is what mixing studies tell you, very simply. They just allow you to differentiate if the issue is factor deficiency. If it is factor deficiency, I will run factor assays. If it's an inhibitor, then we have a different protocol to work with. We'll discuss it next time because it's quite extensive. Any questions about the mixing studies so far?
No.
All is good? Okay.
Yep.
Now, one last point. When I told you that mixing studies, when I run them, the results should go back to normal, then I say the mixing study is okay. We call this correction. So when the result, when the patient sample, I run mixing study for it, and the clotting time of PT or APTT goes back to the normal range, let's say, we call this correction. Now, mind you, when I say that the mixing study suggests that the patient has a factor deficiency, the result will not always go back to within the normal range. Interpretation of mixing studies is a bit of a complicated topic. Okay, so we cannot just say, oh, my result is 2 seconds out of the reference range. It's not corrected. No. This is an inhibitor. This is not how it works. It's a very number-driven approach with mixing studies. So sometimes actually the issue is a factor deficiency and you run a mixing study and the result is still out of the reference range, but actually it is corrected. So then how would I judge? How would I know? We have many ways. We have something called the Rosner's index. We have something called Chang's index. We have something called percent correction. We have cutoff values, etc., etc., etc. Okay, which one is better so far? The ISTH recommends you best to use something called the Rosner's index. How does it work? A discussion that we can do at another time because it's a bit extensive as well. No time to discuss it at the moment. Okay, so this is a very, very important point to consider. When, again, I talk about correction and mixing studies, I do not mean that it goes back to the reference range. That does not always happen. Many corrected cases are still outside the reference range. Okay, so this is a very important point to make. This depends on the reagent, this depends on the patient, this depends on the pooled normal plasma. So it's very important to consider this point. By the way, I will definitely share with you this presentation. The slides that I will share with you have more details than these. I don't want to just give you a ton of text for you to look at. Some slides, they have something called check notes at the lower left corner of the slide. This means if you open the notes of the slide, you have a lot of details that you can read through about the content of this slide. Okay, and I think it's important to go through. Now, we will go over the basics that we spoke about, fibrinogen, because we also have D-dimer and others. So for fibrinogen, what would I do if the results of fibrinogen are abnormal? Because at the end of the day, this section is about if your result is abnormal, what to do. If fibrinogen is low or high, okay, then we don't really have something like the mixing studies to work with, because mixing studies are a fairly standardized approach. PT or APTT are prolonged. I don't know why. I go to mixing studies. Simple as that. For fibrinogen, you don't really have that. Okay? Because for fibrinogen, it depends on the context of the patient. Why am I ordering fibrinogen for this patient? Am I checking the fibrinogen replacement therapy? Am I monitoring that? am I asking for it because the patient, for example, maybe has DIC and I'm monitoring that? Why exactly is it? So really it depends on the situation of the patient and depends on the request of the clinician and what the clinician wants to see. So we don't have the equivalent of mixing studies for fibrinogen. That does not exist. Okay. And remember, fibrinogen defects, that is mutations or structural issues with fibrinogen, can cause prolongation of the clotting time or shortening of the clotting time at the same time. So fibrinogen qualitative issues can cause either an increase or a decrease. So you cannot really know much just by looking at the result. You have to know the context of the patient as well. And I know for the lab, this is not always something available, and that needs the opinion of the physician on what to do next. So we don't have an algorithm. If your fibrinogen is high or low, do this or do that. Okay. It depends on a lot of things. And for you to really find out the diagnosis or the real cause behind the low or high result of fibrinogen requires some very specialized tests. Okay. And we can use thrombin time to assist us in this kind of work. You will see in a second. Okay. Yes, thrombin time. Now, if you remember, I told you thrombin time can be prolonged if you have heparin, if you have thrombin inhibitors, or if you have a problem with fibrinogen, or if you have fibrin-fibrinogen degradation products. Okay, so the breakage of the clot will produce fibrinogen degradation products in high amounts. These can interfere with thrombin time. Anyways, if thrombin time is prolonged by something related to heparin, then how can we say it's a fibrinogen issue or a heparin issue? All of these issues can cause a prolongation of a thrombin time. Now, we have a sister test to thrombin time. This test is called riptylase time. Riptylase is a protein, okay? It's a proteolytic enzyme that is extracted from a certain type of snakes. Now, this riptylase time works very, very similar to thrombin. There is one small point, one small difference between thrombin and riptylase. Thrombin is sensitive to heparin. Riptylase is not sensitive to heparin. So usually I run both of them together if I need to know, does the patient have heparin or is there heparin contamination in the sample or not? So if I run a thrombin time and it's higher than the cutoff, let's say it's higher than 21 seconds or 22 seconds, and then I run riptylase time, and riptylase time is within reference range, then in this case I say, the patient likely has heparin contamination in the sample or the patient is taking heparin medication treatment, okay? Because again, riptylase time is not sensitive to heparin. Thrombin time is sensitive to heparin. So if riptylase time is normal, but thrombin time is prolonged, we say with very good level of confidence that the patient has heparin in their blood or the sample is contaminated with heparin. If both are prolonged, thrombin time is prolonged, riptylase time is prolonged, then it is very likely to be a problem with fibrinogen or the presence of fibrin and fibrinogen degradation products in the patient blood. Is this point clear? Should I repeat it?
Clear.
Very good. Okay. Now, the next point, and that should be the last for our presentation, is a summary basically of what we were just saying. If the anticoagulants or fibrinogen issues are suspected, okay, then the appropriate anticoagulant assay may be run. Because, for example, if I'm suspecting heparin and fractionated heparin, low molecular weight heparin, what kind of anticoagulant is causing a problem? Is it dabigatran? Is it argatroban? I have to run the specific assay for that anticoagulant for me to know. Okay? So if a thrombin time is prolonged, what do I do next? It really depends on the context. There is no one size fits all kind of answer. Okay? And this pretty much covers what we wanted to talk about because the rest has to do with DIC and FDP, and we didn't talk about those. Okay, we'll come back to them in the next presentation. So for now, Brahim, if you wish, you can stop the recording or you can keep it if you want to record the questions. It's up to you. So if anyone has any questions, please let me know and we can discuss them now. So no questions, I assume?
Yeah, no questions.
Okay. So I hope everything was clear.
That's very clear.
Yeah, yeah.
Okay, excellent, excellent. That's very good. I will share, by the way, the presentation with Ibrahim by the end of the second session. I'll share it in PDF format, so you should be able to see the notes in the slide notes very easily without having to open the notes one by one. For the time being, I will get back to you with an answer about what time is best to collect samples from dialysis patients. Anything else that you want me to check for you or get back to you on, or we are good for today?
That would be all right for now. And thank you for giving us your time and
Absolutely, it's a
conducting
pleasure.
this training for us.
Let me know what is the time of the next session. I have next week is free, the week after is free, but the 21st of September to 27th of September, I am out of the country traveling. So that's the only week where I am not free. Otherwise, it's up to you. Even October, most of October, I'm free. No problem.
Okay, we'll discuss it with Ibrahim and let you know through him.
Inshallah, inshallah.
Sure.
I'll wait to see you, inshallah, by the next session then.
Oh, thank you.
Thank you too. Thank you, everyone, for your time. And inshallah, talk to you next time. Thank you,
You.
Ibrahim, for arranging this.
Yeah. Thanks, like.
Okay, then.
Bye.
Assalamu alaikum. Have a good